Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing another really fascinating guest today involved in creating a better tomorrow for millions of people out there. Today, we have the honor of being joined on the show by Dr. Susan Kressly, who is the president of the American Academy of Pediatrics, an organization of over 67,000 pediatricians in the United States, committed to optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. Dr. Kressly is board certified in pediatrics as well as clinical informatics, and is a fellow of the American Academy of Pediatrics. Dr. Kressly has also been at the forefront of innovation, advocating for things like pediatric functionality and health information technology. And she has also, in addition to pediatric expertise, broad expertise in quality improvement, healthcare financing and payment systems, practice management, and ultimately optimization of various clinical workflows. Dr. Kressly did her undergraduate work in biology at Moravian University, her medical degree here at Temple University School of Medicine, and then served a residency at St. Christopher's Hospital for Children. She began practicing an independent practice in Doylestown back in 1990, has been a very involved member of the medical community since then, and her independent pediatric practice has been recognized as a medical home, a topic we'll be getting into today on the show since 2011, a model that she strongly believes that all children deserve, and the importance of having access to pediatricians and a broad range of these important services. So honored to have with us. A lot to get into today. Dr. Susan Kressly, thank you so much for taking the time to come on the show.
And thanks so much for having me and giving me the opportunity to speak with your audience.
No, it's wonderful. I really look forward to everything we're going to be talking about today. So I'd like to just start off, as we typically do, by handing you the floor for a few minutes just to talk a little bit more about you. Would love to hear a little bit more about your background story. I know you're local, which is exciting, but why biology, why medicine, and why ultimately did you get involved in pediatrics?
Yeah, so thanks for that. I think I'm one of those people who is permanently stuck as a toddler, wandering through life, asking questions and being curious about, like, how does this work? And why does it work that way? And couldn't we do it better? And who do I talk to fix it? And all of those things that sort of, keep parents and grandparents crazy because kids are always asking questions. I am that curious questioner who constantly wants to move the needle and grow and learn more and do things better in a more just way. And so that's really what's driven me. I didn't actually have a pediatrician when I was growing up. I had a family doc, and his office was down the street from where I grew up. And he handed out lollipops. So I spent a fair amount of time riding my bike down to the end of the block and trying to get lollipops from the staff, and just poking my head around and asking, what's this and what does that do and what's that funny machine for? And my family doc at some point said to me, hey, you should come be me and be a pediatrician. And I was like, and be a doctor. And I said, well, you take care of smelly old people. Like, that doesn't seem like very much fun. Of course, now I am a smelly old person, but he said, no, actually, there is a doctor that can just take care of kids, and that's a pediatrician. I'm like, really? You can do all the cool stuff, but just take care of kids and watch them grow up and do cool things? And he's like, yep. And I'm like, okay, that's what I want to be. And so at 4, I announced to my family I was going to be a pediatrician. And like most parents do their kids, they're like, okay, sure. But I really consider it a calling because through the rest of my training, it's really where I was directed. I got hijacked my senior year in high school, um, where someone said to me, "Don't you want to be there when your kids learn to tie their shoes and say their first words?" And that's really hard as a female physician. And I was like, "Well, maybe I should be a nurse." And so I went to nursing school for a year, and it took me about a couple of months in to go, don't think this is a good fit because I'll be trying to figure out who's the decision maker and change their mind. And so that's when I ended up studying biology, went to Moravian, and then on to St. Chris. And picked St. Chris on purpose because I'm one of those people who learns by doing. And at Temple Hospital and St. Chris are in a very under-resourced, underserved neighborhoods where it's all hands on deck to do whatever you can to serve the community. And that's how I learn best. And I like to solve problems and sort of go upstream to address things. I mean, long before social drivers of health was a thing, you can't help but train in an urban environment that's under-resourced and understand that lack of affordable housing, access to healthy foods in high crime, low educational opportunity environments, there's huge impacts on health. And so it's really stayed with me and guided me in trying to make the world a better place by investing in kids.
Outstanding, outstanding, and I agree with you. I also am a perpetual toddler, and but whatever. It's but I very much appreciate that message, and especially with the theme of the social determinants of health being such a prominent one nowadays. And again, definitely appreciate that background. So going through a lot of your publications prior to the show, I came across a term that I guess as a father of three children, well, they don't see pediatrician anymore, and myself, I saw a pediatrician for 18 plus years. I was very unfamiliar with the term a medical home, which is not a building or a place, but this concept that recognizes really the importance of the partnership, in essence, between healthcare professionals like you and families, comes with a set of priorities in terms of accessibility and comprehensiveness, compassionate care, and goes back to to 1967. Actually, I think was originally a theme developed for children with special needs. But I was wondering if you could take us into this theme because it comes back several times in your work over the years, and I'd love it if you could just take a little time to introduce it to us.
Yeah, I'm happy to. And it's something I'm very passionate about. And you're right. It was started in the 1960s when it was realized that, especially in kids with special healthcare needs who saw multiple specialists, it almost felt like there was no one who was captain of the ship and saw them as a whole person in context of their family and their community and their day-to-day life. And so grounding all of the care for those kids in a place that's led by a pediatrician and a pediatric led team that really could sort of be the home base to let's start with us. Let's figure out, do you need to see a specialist? Do you need to go to the emergency room? Is this something that we can address in your home, in your school, and really take a broad whole child approach to looking at problems? And then we realized that's not just important for kids with special healthcare needs. And in fact, the adult population, the adult medical literature sort of tried to co-opt that term. And this is a problem in adult medical care. For my own family, I've seen it in that so much of adult care is subspecialty related. And so, for example, you go to your GI doctor because you're having belly pain, and he says, "Yeah, it's not your GI tract." And you're like, okay, so where do I go next? Well, I don't know. That's not my specialty. I only do the GI tract. And so there's this fragmentation without someone really looking at the whole picture. Because in medicine, sometimes there's clues over time that you realize that, wait a second, this belly pain and this rash and this growth trajectory on a growth curve makes me think about this might be celiac disease. And if you don't see all three pieces of this, and your dermatologist sees one and their GI, there's pieces of this that are often not put together. And so the concept of really having one place to start, and I used to tell my patients all the time, when you think there's something wrong with your kid, start with us. If we're not the right people, we'll connect you to people that we trust and that we would take our own children to. I don't know how to deliver better medical care than to do for your kids what I would do for my own and my own grandkids. And so let us figure out the right place to go at the right time and the right venue. And 9 times out of 10, it can be us. And then we have this longitudinal picture of your healthcare and health trajectory in the context of your family. We're also the people who might know, wait a second, we saw the older one last week who had this going on. Maybe this is a related illness, or we happen to know that dad just lost his job. And so there might be, when I write you a prescription, you may be having some financial struggles that I want to be cognizant of. And I'm here to help you and partner with you and be honest with me, and let's have a two-way conversation and shared decision making. So the medical home is really sort of it's coming home to where you start for healthcare. And for kids, sometimes that's learning. I mean, kids, I tell parents all the time, if your kid's not doing well in school, come to us, because maybe they can't hear, maybe they can't see the blackboard, maybe they are anxious and it's getting in their way to ability to learn, maybe they're getting bullied. I mean, there are so many things that impact success in the educational realm that we can help connect as the medical home families to the appropriate resources. Because really the only thing that we care about is that your kid has the best chance of being their best selves in the context of the supported family, community, and environment. And so it's funny you say you had a pediatrician till 18 plus. There are many of our patients as pediatricians who don't ever want to leave us. It's like, can't you still see me, doc? Like I'm home from, like, I came home to visit my family at Thanksgiving and my doctor's not open. It's like, but you're always there. You always open up the office. I remember being there on Christmas Eve when you opened up the office because somebody was sick and you're like, I got to go out for something anyway. I'll meet you at the office. And so having that accessibility and at least starting with us, and if we're not in the office, we can tell you, is it appropriate to wait till tomorrow? How about we do a telehealth visit and just see how sick you are? All of those things, let us be the coordinators and the captains of your ship in partnership with you so that you can make sure that that you get the best care you can with the best outcomes.
Yeah, I'm giggling here because I'm 6'6", and I became 6'6" when I was like 16 years old, and I just remember sitting on the pediatrician's table or looking around the waiting room, and all the other kids were staring at me. I'm like, Mom, why am I still here? But I get it. I get it.
So let me just tell you a funny story.
Please.
My goddaughter is very tall. She's a volleyball player and over 6 foot tall. And she was shadowing one day. And one of the reasons I love being a pediatrician is because kids have no hidden agenda. They didn't come in with, I really want to get a referral to this. I really want an antibiotic. They just are who they are. They say what they are. And this little 4-year-old looks up at my goddaughter and said, "Are you a giant?" And like totally, serious. Like, I think that's what giants look like, come from a short family. And she was like, "Oh my God, I had no idea being a pediatrician is so much fun." I'm like, "Oh yeah, it is." Sometimes I sit on I get on the floor when kids are scared and they crawl under the exam table. My nurses laugh at me. They've been known to come in the room and it's like, "You're under the table." I'm like, "Yeah, he wouldn't get up, so I just joined him where he was," right?
Yeah.
Like meet the kids where they are to be able to give them the care that they need, which is so much fun. And every day that we show up, there's at least one story where some kid makes you laugh, or just tugs at your heartstring, and you're like, "Yeah, that's why I did this."
Oh yeah.
Still makes a
Oh, yeah.
difference.
I get it. I get it. Um, So while we're on this topic of the medical home, you wrote this interesting piece in May of 2017 in Pediatrics entitled "Non-Emergency Acute Care When It's Not the Medical Home." And at the time, this evolution has continued, but all sorts of stuff out there now beyond the hospital emergency room, urgent care facilities, clinics in the local Walmart. I'm a pharmacist by undergraduate training, so a lot more than pharmacy occurs there nowadays. Say a couple of words about this because clearly a very different environment in 2025. We can't always get to our pediatricians, but nonetheless, as you're explaining, there is a reason why we should go to the pediatrician. Just say a couple of words about this paper, if you would.
Yeah, so it was really in response to unmet needs that families were really feeling about where do I get care? And we're all living in a very sort of sped up environment with just-in-time access to everything, right? Like if you ask my 31-year-old son, when's the last time you were in a bank? He'll be like, you go inside. Like they have no
Right.
idea, right? Like it's
Right.
everything's on your phone or it doesn't have value, right?
Yeah.
Or you drive through and you order it and get somebody to deliver it.
Yeah.
So as that was happening, there was a real big discussion at the American Academy of Pediatrics about how do we make sure that kids' needs are met in this burgeoning environment where everybody wants a quick in and out, make it easy. And some of those actors who are playing in that space are completely driven only by the finances, don't really, they have a finance model. How do I make money off seeing patients versus how do I make sure this person gets the best care that's them at the right place at the right time? And so that's where that paper was driven by. Now, there are some pediatric offices, and I was at since 2004, I opened up a solo practice and then grew it. My whole thing was giving families access to me to get rid of all the layers of handoffs and pass-offs because when people want their pediatrician, they want them. And so we took our own call, answered our own phone calls for many years and had direct access. And people didn't abuse it because they really valued it. But there were even for us times where families would be traveling or about to get on a plane and at the airport. And so how do you make sure that they still get the best care that they need in an environment where you can't always meet it in their medical home? And so the gist of the article was really give us a call first as your medical home, or now shoot us a portal message, or now chatbots. Like technology is making this much easier for us to interact with families that we have a longitudinal relationship with. And then let us help you decide what is the right place for the right care at the right time. And sometimes it's urgent care, sometimes it's the emergency room, sometimes it's direct to a specialist. Let us help you sort of be the concierge. And then when those places do take care of kids, it is really important for families to understand that they don't have the same level, all have the same level of pediatric child health centered expertise. And so you could go to urgent cares a mile apart, and one of them is staffed by people who are pediatric experts, and the other is a person who's only had minimal training on taking care of kids somewhere along the way. And so you really want to know what's in your neighborhood and what's accessible. And then as the pediatrician who's responsible for your overarching care, I want that entity to send a report back to me, because when your kid's not better tomorrow, you're not calling them, you're calling me. Like I went to urgent care yesterday, and so having this close the loop back is important. So making sure that all of the entities where kids go, and that's actually true of emergency rooms. In some rural areas, emergency rooms don't really have child health expertise.
Right.
And that's where your pediatrician can sort of help you and say, hey, when you go here, make sure you ask to see this person, or don't forget to tell them that you don't have a spleen, right? Like there's
Okay.
and and the kids are great, right? Like kids are such technology people. They're in the ER and their dad's like, they went on vacation and needed stitches somewhere, And then the nurse asks them, when's your last tetanus shot? And the dad's like, I got no idea. And the kid goes, Dad, 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 it's on your phone. Just log into to my doctor's website. You can get it on the phone. And the kid's right. So like having the access to information so we can sort of information share in a way that's real time and close the loop. But I want to go back to one thing that I skipped over, but is really important.
Okay.
There is nothing, I think, more impactful for patient care than having a longitudinal relationship with someone you trust. And for the listeners who do not have that, I would say, please work hard to find it, because there is nothing better when you're in your greatest moment of need and frightened to have someone that will promise to take the journey with you, who you already know and trust and have a relationship with. It is scary enough. And sometimes it feels like it's just a sore throat. It doesn't matter who I see. Anybody can swab my kid's throat for strep throat and what have you, until someone looks in that person's throat and said, oh my, you have an abscess. Your child may stop breathing. We have to get you to the hospital. And then all of a sudden people want to go like, wait a minute. Like, I want my mom, or I want my kid's pediatrician, because like they know me, like they'll help me through this. You want a trusted longitudinal relationship. It's best for care no matter how old you are as a patient. I still like my doctor, right? Like who knows me and says, yeah, I know, Sue, don't order too many tests because you think that we over test and I hear your pediatrics perspective on that.
Right. Nice. So I mentioned in your bio that in addition to being board certified in pediatrics, you're also board certified in clinical informatics. You have a passion for innovation and technology. In 2019, March, in Pediatrics Again, you wrote this very interesting piece called "Extending the Medical Home to Meet Your Patients' Mental Health Needs. Is telehealth the answer?" And it's interesting because telehealth also pops up the year following during COVID. You write a piece about different strategies of the managing of neonates, and telehealth sort of plays a role there as well during the pandemic. And I'm just interested, as you're talking about trusted longitudinal relationships, can you say a few words about the role that telehealth has evolved into over the last several years in this medical home or virtual medical home model, and just perspectives on telehealth in general in the pediatric space?
Yeah, so I want to back up one space, and that is, I tell everybody I'm an accidental clinical informaticist, because I clearly didn't go to medical school deciding I wanted to be a tech person, right? Like, that's not why I did this. But when I opened up my own practice in 2002, I made a conscious decision that I wanted to use technology where it actually improved access for kids and family, and leave people where they had the most value. And so I looked at my husband and I said to him, and he's a tech guy, I said, honey, can't you just build me a website where people can register themselves? Why would I have to pay somebody to mistype somebody else's name into a computer when people are used to self-registering? And why do people have to call me every time they register their kid for kindergarten to get their immunization records? Like, why can't they just print them out at home? And so for me, technology was, how do I make care delivery better for both the care team and the families? Not build technology and then try to fit it, like, who do I sell it to? It's solving a problem through technology.
Mm-hmm.
And so if you think about where we are with patient portals, signing yourself up, scheduling your own appointment, like all of that stuff came to fruition much later. And I think telehealth is a piece of that, as is portal messaging, as is going to be wearable devices, which you can download and get information. There are places where technology really opens up the space for us to be able to have a meaningful connection without families, especially families. Young families work hard to try to keep their lives together. And I don't know how chaotic your life was when you were raising a couple of kids, but There is nothing simple.
No.
And so if I don't have to like leave work early, try to get out of a meeting, go pick up my kid at daycare, drive to your office, not estimate the traffic enough to get there, to get to an appointment, if I can gather that information remotely via telehealth, why not? Well, there's a lot of barriers, including payment ones right now, but if you look at the promise of extending that, now there's times where you have to touch the patient, but there's times, especially with mental health, there's incredible insights you get when a family invites you into their space to be able to have an exchange. I can't tell you, doing anxiety, depression follow-ups with teenagers, how impactful it is to have them. They're usually in their bedroom. It's like, what's that picture on your wall? Tell me about that. Or you see things, or I've had appointments where I've said to kids, show me where you sleep. And it's like, oh God, no wonder you're like tired and anxious and depressed. There's no way you can get a good night's sleep sleeping on a futon or a couch somewhere in a room with 6 other people, right? Like, there's so much insights that happen
Yeah.
if you get invited. Plus, it changes the balance of power. If you remember sitting in that exam room, probably with a stupid paper gown on,
Oh yeah.
which which I stopped doing in my office because it actually doesn't add value to most exams. But if you come into my office and take your clothes off and sit on my exam table, there's a balance of power where you feel like I have no power here. When someone invites you into their home, they're in control and it's their power. And there is something very different about and insightful from a clinician side about meeting people on their turf, not always making them come to your turf. And we're going to get to the point where, every iPhone's going to have like take a picture of your ear so I can look in it, and stethoscope. And some of that technology already exists. It's too expensive to be deployed in an equitable way. But it's going to keep happening. And so I think that we have to be open to innovation if it really improves equitable access for every patient, and doesn't compromise care. Now, there's a difference even between telehealth offerings, right? Because there are telehealth platforms because that's all they do, and that's not your medical home, and that's the sort of urgent care quick fix. I don't want to leave my house or my office to quick be able to get a prescription to do something. But there's a difference if it's the medical home extending beyond their walls to
Mm-hmm.
meet you where you are. Because I still have a brick and mortar place, which means if I say to you, "Ooh, that your kid breathing makes me uncomfortable, come on in, I'll squeeze you in whenever you get here between the patients." Or if I see a young child and a mom who's like, it's winter and you know what it's like to put your kid in the car seat and try to get like anywhere. It's a long, painstaking process,
Mm-hmm.
right? And then they throw up, and then you have to,
Oh yeah.
all of that, right? So if it's a kid I see who's having trouble breathing, who might have RSV, for example, or a bad cold, I can say to them, listen, let's connect via telehealth tomorrow so I can see how your child's breathing. I listened to them today. I know what they sound like. I want to see if they're getting worse, they're getting better. So let's not make you do that whole rigmarole tomorrow and come to my office. Let me connect with you by telehealth so we can have a conversation. I can see how the child's doing. That sort of visual picture might be enough to at least make somewhere in the clinical decision making decide what the right treatment path is.
Mm-hmm. And while we're talking about clinical decision making, this topic of the electronic health record has been very popular lately. Using the EHR to sift through data in every which way to understand different things going on with patients. And again, this was September 2023 in JAMA Pediatrics. You write this very interesting piece documenting psychosocial problems in children's electronic health records. There's a bit in it about the father of U.S. Pediatrics, Dr. Abraham Jacoby, talking about the social determinants of health. Some 120 years ago, and that's great. But again, this is sort of where if it's psychosocial problems, as you point out, related to whatever's going on, substance abuse, violence in the home, a parent's depressed. This filters down to our children. We can use that data and the EHR to find these troubles, this problems early on. Very important aspect of all things happening in health tech nowadays. Love your perspective on this as well.
Yeah, so part of the reason I became an accidental informaticist was the tools out there often were built for the average adult, which I'm still not sure what an average adult patient is. But when you talk to tech people, they sort of build a model around, a prototype, a persona, if you will, and then they build things. Well, it's rarely a kid. And so we struggle and still do as pediatricians that we're using adult technology and trying to shoehorn a square peg into a round hole and make it work for us. And so early on, we realized there's a lot of things broken about the way we document and the way we use electronic health record tools that actually could unintentionally harm kids. And so it's one of the things that we keep saying, like, but kids are different, but kids are different. And so social drivers is a really, and I'm going to make a point of something here. Use social determinants. Determinants infers that the patient is stuck in society, stuck them. They have predetermined to be stuck in this role. I think they're drivers. Nobody predetermined them. The world created a scenario that's driving them in a direction that is not often in their control. And there may be power to change it if we change the drivers in their community to one that are more uplifting instead of one that gets in the way of their ultimate health. So that's why I use social drivers instead of social determinants. But I digress. In any case, so a lot of kids' outcomes and data really depends on their caregivers. There is no diagnosis code in the systems that we use to record what's wrong with patients in our electronic health record for dependent of a caregiver with depression or dependent of a caregiver with substance use disorder. So how do you even document it in a way that's meaningful? Because if you put substance use disorder, which really is impacting the kid, but it's not the 6-month-old substance use disorder, it's the parent. So we don't have really the right framework in context with our taxonomies and our vocabularies that we use in medicine to really record that the right way. And then secondly, sometimes for kids, and this is not just kids, but adults, and I'll get to that in a second, it can cause harm. So for example, there's if a mother reports on a social driver screen that she's got housing insecurity, and the parents are split, mom has physical custody, but they both have legal custody. If that questionnaire ends up on the patient portal, which both parents have legal rights to see, there's been a case where a father saw that and got his lawyer to use it against the mom, and she lost custody of her child because she admitted that she was struggling with housing insecurity with her child. That is wrong on so many levels. We should be lifting that mother up, not using that data in a way that harms her. Think of teenagers, right? As pediatricians, and when you went to your pediatrician, you probably had private conversations with your pediatricians about, sex, drugs, and rock and roll and all those things that we talk about. And you want to have a relationship with your teenage patient. So if they're in trouble, they know that they can call you and you'll have nothing but their best interest in mind, right? How do you protect that isolated conversation from being shared on the patient portal with parents but give them access to the information about their diabetes and their asthma and their whatever.
Yep.
We haven't figured that out. We have
Yeah.
not technology. People made the technology and, version 1.0 went to 2.0, but it didn't consider all of the legal and ethical and other frameworks around the use of applied technology. And often they don't loop back to include kids. So I would propose if you built technology with kids in mind, because what a 6-day-old needs is different than what a 6-year-old needs, which is
Sure.
different than a 16-year-old needs. If you had the mindset from the beginning that people change over time and you built the technology to be part of the life course, think about seniors, right?
Sure.
Taking care of your own parents when they're like I don't want to know what they divulged in confidence to their doctor, but if your parents start to need help accessing healthcare, you want to be able to help them as the adult child, but not betray their confidence and learn that they were treated for a sexually transmitted infection when they were 32. Like, it's none of my business, yet there's no way to separate the information out.
Yeah.
So I would love the tech world to start thinking about how do we individualize and consider data and health trajectories over the entire life course, because I think then every patient wins, not just kids.
Absolutely. Absolutely. Very interesting. So let's go to 2023, because it's now that you get a phone call that you were elected president, American Academy of Pediatrics, and there was a little article that it came, I guess, 1 year after Hurricane Ian had come through. You were living down in Sanibel Island and had some pretty devastation going on at your home at the time, but you survived that. You're elected to to lead the American Academy of Pediatrics. Um, talk about just talk about that for a minute, and why, with all your other responsibilities, this is something you decided you wanted to do.
Yeah, well, it didn't just start that year. I mean, as it happens in leadership, people start tapping you on the
Sure.
shoulders years back. And I got involved in multiple leadership roles at the American Academy of Pediatrics, first in the Pennsylvania chapter,
Sure.
and then at the national level on health IT and medical home, in part because it was that curious question, like, is somebody doing work on this? Because I think there's a voice missing at the table. And people laugh at me and say, yeah, just if you don't invite Sue to the conversation, she'll bring her folding chair and invite herself. Because I really believe that sometimes decisions are made that are so remote from patient care delivery, that mindset needs to be at the table. And so my whole clinical career, I was asking questions, pushing envelopes, knocking on doors. And people, when you say, like, who's working on this? And people go, no one, we don't think. Do you want to do it? And I'm like, it can't get any worse than it is. Might as well be me. If no one else is, I'll go where no person has been. But I'm one of those people who is willing to be bold and make mistakes and ask a lot of questions, and sometimes make people angry because I make them think differently. But that's always been the way I've been. And so people kept saying to me, Sue, like, you have to apply for presidents. And I'm like, I don't think so. I've started my own practice. I grew it. I'm getting to the point where my husband and I want to, like, sort of retire from. I want to retire from clinical practice. I want to do consulting and have sort of all those years that I missed in my own kids' life, have access to my grandkids and be able to have fun. And somebody sat next to me at meeting, and I'm like, oh no, don't sit there. Please don't sit there. And they're like, yeah, you should apply. I'm like, okay. And I'm like, why? And they're like, because you have unique skill sets that are a combination of a bunch of things that pediatricians and kids need in today's world. And I'm like what? They're like, well, you have this weird, you do clinical stuff, the business of pediatrics, you're a health IT, you're an innovator, you're a disruptor, always on the side of the North Star of doing what's right for kids and those who take care of them. We need bold thinkers, for bold times. Little did we know back then how much this might have been necessary. And my whole practice career and training was in Philly, which somebody said to me, "So you're the Jason Kelsey of pediatrics. Like, just get everybody behind me and like just push us a half a yard in the right direction. That's all we need. We just need somebody who's got a big heart for the right reasons, but isn't afraid to do hard things." And so I took that as a huge compliment. And it's really been the privilege and the pleasure of my professional career to be able to be in this position and travel all across the country and get to be the voice of pediatricians in many places, in the news, in DC, in state offices, in the House of Medicine, just trying to elevate the conversation about what kids need and the pediatricians need in order to be able to have the right resources to do our best jobs.
Excellent. Excellent. And yeah, let's talk about some of these programs, and there's quite a bit that goes on, per the academy. But I thought, again, with your background in technology, in clinical work, I thought a discussion about this PROS system, also known as the Pediatric Research in Office Settings, part of this is the practice-based research network of the AAP. It was established back in 1986, but there's a couple components to it, and I thought one that well, you could introduce us to PROS, but then one of the pillars underneath that is something known as the CER2 Consortium, or Comparative Effectiveness Research through Collaborative Electronic Reporting. That's a mouthful. It sort of trickles down to what we talk nowadays about real world evidence and the ability to whether it's pediatric hypertension, ADHD, antibiotic stewardship, a way to really coalesce and understand what's going on across our country in various practices, compare notes, talk about PROS, and talk about the CER2 consortium, if you would.
Yeah, this is the power of the pediatric office, if you ask me. And to the folks that came before me and started this and just had the insight that so much of pediatric research is done in silos of academic institutions in mostly urban environments, yet that's not where most of the kids are taken care of. So when we do, for example, research on what is high blood pressure in a kid, like, how do we define it? Where's the normal ranges? How do we decide what normal ranges are? If you take a population that's an urban population with a different race, ethnicity, and underlying social drivers and health conditions, you're going to get a very different picture than if you go in the middle of Wyoming, where there's one pediatrician in a whole county taking care of kids. And so they realized really quickly that if you can get to where care is delivered across the country in wide various geographies, rural, suburban, urban, small practices, big health centers, all of that, you get a way bigger representation of what is the reality of where kids are and what is happening on the ground. And so it started initially with, filling out, recruiting pediatricians in the middle of nowhere who like to move the needle, to impact. How can you as a clinician in the middle of your community impact research on what's best for kids? And pediatricians are all about that, right? Like, because so often we'll see studies and go like, well, that doesn't look like the kids I serve. Like, how do I know if I can apply that knowledge to my population? Because it feels like I'm applying apples to oranges, and that just doesn't feel right, right? And so people were signing up, and at those times it was hand entering data or finding and collecting it in different ways before there were electronic health records. And then once we started to really get almost ubiquitous, and there were early adopters like me who were early to the party, where we're like, okay, it's less onerous for me to give you more data. If you can just come suck it out of my electronic health record, I'm recording it there anyway. Is there a way that you can just pull the data out of there and normalize it from different EHR platforms to get what you need? And that is what's driving that. And then CHR squared is really the consortium of sitting in the background and pulling and feeding data almost behind the scenes. But it's because that's been such a low lift for pediatricians to really involve their work and in changing the research. It's allowed pros to do interesting things like take two sets of pediatricians. Some of them teach them, was a great one about vaccine confidence on HPV vaccines.
Mhm.
Let's give a group of pediatricians training on the most effective way to get families to say yes to immunizing against that cancer protective vaccine, and then have a control group that doesn't go through the same training. And let's track the data and see, is this really a big difference? Can we improve vaccination rates for HPV across various different populations across the country by having an intervention? And the answer was recently, it's either about to be published or is recently published. The answer was yes. So then everybody's like, well, can I get the training? Can I get the training? Because we all want to do this work and we think it's important. And so then it guides clinical guidance and resources that we have at the American Academy of Pediatrics, so that pediatricians across the country can, take advantage of that training so that it increases the ability to do it. So it's really impacting pediatric research from boots on the ground using technology. That's really a pretty low lift. During COVID, there was some early questions where people were going, "Hey, are you seeing that? Are you seeing that?" Unfortunately, we're not nimble enough yet to be able to sort of on the fly pull queries, because a lot of these are funded studies that you have to go through protocols and get
Sure.
approval of the research to do. But just think of the power of the information that's sitting somewhere that through the pandemic, and we found ways to really gather data quickly at the American Academy of Pediatrics through the COVID pandemic, because we were doing the best we could to give the best advice that we had at the time. And pediatricians, unlike a lot of other medical specialties, like we all help each other. Like we're all ready to feel like we're the under-resourced, we're the lowest paid specialty in the house of medicine. Most people don't know this. Your pediatrician is paid less than any other doctor. And now I think we should get paid more,
I think
because
so.
although kids are 22% of the population, they're 100% of the future. And we always have more than one patient, because there's often at least one parent, sometimes two, and sometimes they don't agree. And in the mix of having the conversation, and we can't just tell patients to go home and do something. They're dependent on their caregiver to make sure it happens. So I quite frankly think we should get paid more than our adult medicine colleagues. But that's for a future conversation.
Got it. Got it. It's interesting among the various studies that the organization has been involved in running. There's a bunch here on sort of, I'll just classify them as sort of injury prevention, whether it's everything from suicide, adolescent drinking. Just the other week, we profiled this new program of the Ad Council known as Agree to Agree. And we talked about this horrifying statistic that now 3 years in a row, leading cause of death, ages 1 to 19, gun violence. I mean, I remember my pediatrician, say, "Are you playing sports? Are you eating right? Do you want to talk? Do you have friends?" They didn't talk to me about guns and some of these bigger issues. But can you say a few? I mean, obviously, this is not something. Maybe it is, but when you were practicing 20 some odd years, these are new themes that obviously in a period of time in the medical home that you have to talk to your patient. You have a lot more to talk about now, things that we probably didn't think we'd be talking about with kids 1 to 19 back in the day. Can you say a couple words about this and a little bit of what you learn in some of these clinical experiment or trials that you work with?
Yeah. So medicine always changes, right?
Yeah.
We don't see nearly the amount of ear infections that we used to because, in large part, because of the pneumococcal and Hib vaccines.
Yep.
And so, if you pull up the list of the most common diagnoses in the pediatric office from when I started practicing in 1990 to now, you'll notice a shift in diagnosis. So, our conversation should shift to reflect what is happening in healthcare and child health status across the board. And so that's not very nuanced. And by the way, the gun conversation has always been a pediatrician frightening statistic. Well, especially
Yeah.
when you trained in Philadelphia and you
Yeah.
saw that, like all it takes is one kid to be stuck in your brain for your entire life. And I grew up in Red Hill, Pennsylvania, a small town in Montgomery County, where my father was a hunter, and he took me hunting with him, right? So there was credibility. I said to when my son was growing up, I was the pain in the butt mom who would say, before my kid comes to play to your house, do you have a pool in the backyard? And do you have a gun? Do you have a gun in the home? I'm not
Mhm.
judging you. I just want to make sure that you have the safeguards in place to keep my kid safe in your home if he's coming there to play. And because I grew up with guns, and I could dress a deer if I had to still probably. But those questions to me are okay and just part of normal life, taking care of families and at different ages. And the problem to me is some people are not comfortable. I'm always said I'm one of those people who's comfortable being uncomfortable. If I'm making you uncomfortable, I'm sorry, but my job is to protect your kid. But I think that there is some incredible power here with technology that we are not tapping. And that is, there is no way in a visit to your pediatrician that I can go through all of the possible things that I really want to give you to guidance to keep you safe. Like, there's just no way. Like, you'd have to be there for 2 hours
Right.
and you'd check out. And if you're the mom of twins who are screaming, you didn't hear anything I said after 5 minutes into the visit, because it's like you're trying to have your kids not destroy the exam room. It's the reality of being able to absorb information in those buckets of time. And we have handouts and we put things on portals. And I stopped giving handouts because they end up in my parking lot. I send information on portals, but I can tell you the number of click-through rates, and they're small. Here's where I think technology is powerful if I could convince somebody that this is a worthwhile project. So any of your tech people who are interested, come talk to me. So if you think about it, there is nuanced information about every child in that electronic health record. There is technology to personalize information, including taking my voice and making Vimeos or audios that sounds like I'm giving you an individual message. Why is it that every 5-day-old doesn't get a text message with a voicemail from me that says, I know you're so excited home with your 5-day-old and you're the most exhausted you've ever been in your life. I hear you. Please, please, please don't fall asleep holding your child. Put them on their back in their crib. It's the safest thing to do. If you're having
Hmm.
trouble, I'm a phone call or a text away. You can do this. We're here to help. I mean, as a mom home with that kid, you would be like, man, my doctor cares about me. But there are themes of automated messages like that, which you could customize. What about oh, it's the first cold day in the Northeast, and you know what the cold day is because the weather tells you. Like, don't put your infant in their suit in their car seat. It's not safe because the slippery car snowsuit makes the car seat not as effective.
Yeah.
Pull them out and put a cover on top of them. Like, all of that is knowable with information that's out there and could be customized in messages in different languages with cultural appropriateness and pushed to families in a very customized way that makes them feel cared about and cared for. But I can't convince anybody to do it.
We will help spread the word on that one. Um, so if we look at sort of a little bit over the horizon, I'm sitting here in downtown Philly, sort of equidistant from your stomping grounds at Temple and Drexel and Chops right over here. And, one can just, throw a stone and hit some advanced tech. Temple, they've developed total liquid breathing technologies for neonates. Chops got work in artificial womb technology. We profiled Amy Throckmorton over at Drexel in pediatric engineering and artificial hearts. What gets you excited in terms of the technology picture? If you look out 5 years, 10 years, what are the things that you want to see happening in terms of pediatrics and pediatric technologies?
So the cool thing is, I think the research and the technology has the power to completely change lives. If you start looking at genetic technology, I mean, think about changing kids with sickle cell disease genes so they no longer have disease. Like, you just completely change their entire life trajectory. However, it's really expensive. How do you measure the investment up front to change a child's whole life course when insurance companies will be like, well, but they might not be on my insurance by the time they're 20, so why should I pay for all the money up front? Like, there is a financing piece of promoting health, child health and wellness, and investing early that we haven't figured out how to solve. I think the research is going to lead us to life-changing alterations. Think about GLP-1s on steroids, right? Like, we're going to have the ability to impact people's lives so the chronic diseases that you're seeing in adulthood go away or are moderated or blunted, but it's going to take an upfront cost. People have a hard time figuring out how to invest money upfront when it's not on their business ledger 30 years from now. And to me, that is the biggest challenge. I think the science is going to get us to cool places. Some of it's going to be hardware, some of it's software. I think AI, if applied right, has the ability to give us insights. But again, if it becomes the electronic health record and they make it for adults and apply it to kids potentially get harmed. We have to figure out what's different and how do we apply it in a way that really works to elevate child health. Isn't just using something that was made for grownups and trying to retrofit it, because that's not going to give us what we need. The bigger challenge for me at the science is how do you convince the world that investing in child health is the right thing, not only for that child, but for society and all the cool things that those kids are going to do when they grow up.
Right. And speaking about investing in the children, I'm familiar with a really cool technology known as a vaccine that prevents multiple diseases in certain cases. Our Hep B vaccine keeps you from getting liver cancer. We talked about papillomavirus and cervical cancer. I follow you on social media, and I know you've been down at Washington a lot lately. Kind of an odd era we're in. But if you could talk about what you're doing down on Capitol Hill, what you're talking about, priorities for 2025 as you're down on Capitol Hill, would love to hear your message on this important topic.
Yeah, it's interesting. In many ways, what's new is old, and what's old is new, right? Yeah. And so the two biggest things that we care about right now in advocacy at the American Academy of Pediatrics are vaccines and Medicaid, sustaining Medicaid. Let's do sustaining Medicaid first, because I think it's easier. Most people don't realize that nearly half of children in this country, stop for a second, nearly half of children in this country are covered by Medicaid or the Children's Health Insurance Program. That is half of our kids on public insurance. So there is no way that you don't impact significant Medicaid cuts without harming children. And for people who think those are the kids on Medicaid that'll be harmed, it's a false assumption. If Medicaid funding gets dropped, every kid's going to get harmed because 60% of children's hospitals funding and their recurrent revenue comes from Medicaid payments. If you cut Medicaid payments to the children's hospitals, they're going to have to decide what programs they're scaling back or cutting back. And so if your kid with commercial insurance happens to have a horrible life-threatening illness or injury, there may not be access for you no matter what kind of insurance you have. And if you happen to live in a rural community which really relies on Medicaid, those pediatric beds are closing all across the country. What happens if there's a flu and measles epidemic at the same time and kids are flooding hospitals? There will be no one to admit your kid or for their mental health care crisis, no matter where you live, because the whole infrastructure of pediatric healthcare delivery depends on adequately funding Medicaid. And so we got to save Medicaid. So that's number one, vaccines. I want to remind listeners that the vast majority of Americans support vaccines and the vast majority of kids are immunized on schedule. And so the amplification of the doubters and the mis and disinformation is doing a horrible disservice to kids and parents. And I've got, my own kids are in their 30s, right? And I've got two grandkids. Like, they've not seen all of the horrible diseases that I saw early in training at St. Chris. So they don't know what they're supposed to be worried about. And when the amplified voices of people in power who are making them doubt themselves, they're really, really doing a disservice to the families and young families of the world, and including, remember that this is 100% of the future. So if you want to really make our country healthier, you do a couple of things. You invest in child health. You make sure every child has adequate access to vaccines, which have been a game changer in America history for kids living longer, healthier lives with less infections. And you save Medicaid, which is the infrastructure on which healthcare delivery is built on. And so I'm all about talking to whoever will listen to me. I'm happy to partner with anyone who wants to make children healthier. They are 100% of our future. And when we invest in them together, that's where we get the biggest bang for the buck, because they're the people and the leaders of tomorrow. They're our workforce. I don't care what state you live in. You depend on a workforce. They need to be healthy. Kids went from 36% of the population in 1960 to 22% currently, and they're not as healthy as they used to be. Help us as pediatricians make that healthier tomorrow so we all have a workforce that's healthy and can thrive. And let's make it so that every kid, no matter where they're born and no matter what community they live in, has the same opportunity to be healthy and thrive.
Awesome message. Awesome message. And along with that, we also want our pediatricians to be healthy and survive. And I know I've seen you write a little bit on pediatrician well-being, and as those amplified voices which spread misinformation provide this disservice to kids and parents, obviously that hits the 67,000 of your members.
They are making our job much harder, and it doesn't need to be. And so really it's hijacking our ability to address the things families really want to ask us about. And so we can lift them up by having what should be a settled conversation. And it's not, which is makes it hard.
Right.
I'd still want families to start with your pediatrician who you have a trusted relationship with, because we'll tell you the real story. We have no hidden agenda. There is no hidden agenda. We aren't making money on giving vaccines. We're only doing what we know works to keep your kid as healthy as possible. We've sat by bedsides and taken care of tragically ill kids. We want to save you from having that experience because it is heartbreaking to watch and be part of, and you don't want to go there if you don't have to.
Yep, absolutely. Sue, final messages while we have you today, and I really do appreciate your time, talking about all these topics. But anything else coming up for 2025 that we should know about, per Dr. Susan Kressly, whether it's in clinical practice, your role at AAP, on Capitol Hill, anything that I missed while we have you today that you want to mention, please?
Yeah, just that I want everybody on Team Kids, right?
Yeah.
Like, I think that we as pediatricians tend to often fight this fight ourselves in advocacy in the House of Medicine. It's going to take community partners. So go find your pediatrician and say, how can I help? How can I help you spread the message? I understand the value of kids. I had no idea so much was at risk to kids. How can I be part of the solution? How can I raise up the voices? I'll go with you to our governor, our senator's office. I'll make an appointment with you. And I don't care if you're a retired school teacher or you're in medicine and do something else, or you serve coffee at the local coffee shop. The decision makers and policymakers need to understand that communities care about keeping their kids' health as healthy as possible and as safe as possible. And let's make it a community groundswell of protecting our kids together. I think that's what we would love. We would love to have partners, and anybody who wants to join the team, you're welcome.
Awesome message. Awesome message. For everybody that's going to be listening to this episode across the various podcast networks, or who'll be watching on our YouTube channel, again, you've been spending time with Dr. Susan Kressly, President, American Academy of Pediatrics, doing really amazing work. Whether it's 67,000 pediatricians to advance and optimize the physical, mental, and social health and well-being of all our children. Sue, I want to thank you for taking the time out of your schedule to talk to us today for a little while about everything that you have been doing, everything going on at AAP. Obviously, thank you for what you do and for all our children. And as we like to say on our show, thank you for helping to create a better tomorrow. The children are the future. They are our tomorrow, and what you're doing is, irreplaceable. So thank you for that. And it was just really a great story, and really enjoyed listening to you today.
Thanks for having me, and thanks for joining Team Kids.
Absolutely. Great having you.